Yes.
Dr. Napier, I'm going to ask you to look next with me at a document from 1979 which describes the quantities of products being produced by the centre and to whom they were supplied. Shomik, could we have GLAR 5076, please? So this is a report of the area medical officer on the health services in South Glamorgan during 1979. And if we go to page 5, we will see that it included a report from you on the blood transfusion service. If we turn over to page 7, we've got a heading statistics and then some figures. So it says, summarised figures for collection of blood and components are shown below and various tables. It refers to the problem of demand outstripping supply is a fairly universal one for the commodity. Availability of plasma protein fraction and factor VIII continues to be a problem, a shortfall in NHS materials necessitating commercial purchases. And then we can see the next paragraph down, summary. And just so that we understand this, we've got donations collected, so that I think speaks for itself, 83,762 donations. Plasma pooled fresh, 16,844. What would the measurement be by reference in relation to that?
I think these statistics have probably been through several hands since they might have left my desk. I think it probably means plasma for pooling rather than plasma pooled. And I think that means that we would have collected 16,000 plus donations and separated and frozen that plasma ready for dispatch to the bioproducts laboratory within the requisite time frame. That's shortly after the blood was collected and made into frozen plasma. The time expired plasma was the plasma harvested from donations of blood which had reached their 5 weeks expiry time, and that plasma would have only been used for materials such as album or plasma protein fraction. It would have been devoid of usable coagulation factor content. It's a long time since I've looked at these statistics, and I certainly I think the term plasma pooled and plasma is a bit ambiguous. That they weren't, I don't think, pooled. I think they were single donations which were pooled later.
And then we can see cryoprecipitate, 15,778. And what would that have been in terms of, again, 15,778 what? Bags of cryoprecipitate? Or?
Yes, each bag would have come from one donor. And so that's 15,000 of the collected donations were used to harvest cryoprecipitate. And that would have been usually issued in small batches to the hospital concerned. So a batch might, for example, have 6 of such donations as being a suitable dose for the patient concerned. So that means 15,700 donations were used to prepare cryoprecipitate, and those donations would obviously not have been available to make the pooled fresh plasma, because the pooled fresh plasma is going to the blood products laboratory to make the factor VIII concentrate, among other things. And if we'd prepared cryoprecipitate from those donations, obviously that plasma would not be suitable for factor VIII production by the bioproducts laboratory.
And then if we just go to the bottom of the page...
Well, just before you do that, can you help with the difference between, or the significance of, fresh frozen plasma as single units as a different category from plasma pooled (brackets fresh)? What particular significance is there in that?
Yeah. The fresh frozen plasma was a material which was, as it says, it's freshly frozen. It's separated from a donation of blood and freshly frozen, and that would have been available for issue to hospitals for various sorts of clinical purposes. One might be a profusely bleeding patient, that the surgeons were worried that they were running out of coagulation factors. And it historically was also used as a treatment for haemophilia as well, prior to the advent of cryoprecipitate. Now, the plasma pooled, that's plasma which is separated, and it's designated for onward transmission to the bioproducts laboratory. It's not intended for issue to hospital. So that's the meaning of that. I'm sorry, it's a long time since I looked at it carefully at this table, but.
Well, I follow that they may have gone through different hands, but before it came out as a table. But presumably, the plasma pool brackets fresh would have been frozen in order to transport it. So
yes, it is. It's separated from the blood donation, frozen, and then made available to transport to the blood products laboratory.
Yes. So the fresh frozen plasma single units is what's needed for individual hospitals, as opposed to the plasma pool brackets fresh, which may be the amount which is, or at least part of it, or all of it, that goes to BPL.
Yes, that's right. I'm sorry about any apparent ambiguity there.
Yeah.
And then if we just look at the bottom of the page, this is so that we don't have to come back to the document, it's on a slightly different topic, but it refers there to during 1979, all donations have been tested by the Organon, and then that's the ELISA test in relation to hepatitis B, is that right? That was introduced in 1979 at the centre.
It seems so, yes. I can't personally recollect the date, but this document suggests it's 1979.
And then if we go on, please, to page 10, I'm going to be asking you a little more shortly about the donor collection process, but just so that we can understand this table, this is donations obtained by area, and we've got the figures there for 1978 and 1979. In relation to the different geographical areas, is it right to understand that there were therefore donor sessions held locally in West Glamorgan, Gwent, etc.?
Yes, donation sessions would have been held in every part of the regions of Wales that we covered. We tried to maximise donation sessions wherever donors were available, so sessions were held everywhere.
And then we've got a figure adding all those up for total civilian sessions. We've then got a very small figure of bled by hospitals. What would that refer to? Well,
this was a rather unusual activity, or an uncommon activity, I should say, and that's where a hospital might have some immediate need. I think perhaps, I can't comment on detail because I don't know the individual circumstances, where a hospital might have collected blood from a donor for a particular local purpose, and I can't. This wasn't something that persisted for long. It was, I think, the transfusion service aimed to provide all the transfusion needs to hospitals, and didn't encourage hospitals collecting their own blood for any particular purposes, because obviously it wasn't so easy for them to comply with the donor selection standards and testing standards that the blood transfusion service operated. And I can't comment in detail as to what these episodes might have been. Sometimes, and this goes back historically a long time, where relatives would be asked if they would give a blood donation in support of a sick child or something like that. But I think this is a historical picture, and by and large, the transfusion service aimed to supply everything that hospitals need. And so the need for bled by hospitals would have been, I think, I hope, eliminated.
And then service sessions, what does that refer to?
Well, I'm afraid I can't recall now. I think it may have been sessions at, for example, the RAF Centre just outside Cardiff, but I'm afraid I can't recall now.
So it might be, as it were, the armed services as opposed to the civilian sessions described 2 lines above.
I think so. I'm afraid I can't recall now.
And then we can see there's two broad categories, general public and then factories and establishments. In relation to factories and establishments, would it be right to understand that there was a form of mobile blood collection with the service going into different workplaces to take blood?
Yes, that's right. There'd be no great difference, but we did rely on cooperation from factories and industrial establishments to provide both space facilities for operating a blood collection service and also a supply of fit and healthy donors. And this obviously reflected the economic circumstances of the times, a flourishing industrial sector with lots of busy factories, and we get a relatively easy to manage operation of blood collection opportunities.
And then if we go on to page 13, we can see here a table headed Economy of Hospital Blood Banks, and then there's a list of hospital blood banks, and then we've shown the volume received from the blood transfusion service, and then the percentages returned, not used and outdated. I don't propose to go through the detail of it, but can you just help us understand the process whereby blood or red cell concentrates or whatever it might be was supplied by the centre to hospital blood banks for transfusion? How would it work? Would it vary from month to month in terms of the amount supplied, or was there a regular supply each month?
Hospitals would request, they would put in orders for blood, some of the busy hospitals on a daily basis or even several times during a day. Their objective would be not only to meet any immediate need, for example, a major accident would have special needs for a blood consignment, but they'd also want to top up their own blood bank with a margin of stock that would be safe. They'd have blood in the various blood group categories, A positive, O negative, etc. They'd want to have a certain number of donations in each of those categories safely stored in their blood bank so that they would be able to manage whatever clinical situation presented itself. Now, the problem that they have to face is that they must maintain an adequate inventory, but blood has a relatively short shelf life. And so some of the hospitals here, which have a fairly high rate of returned unused blood, with the smaller facilities, they have a need to have a stock of blood available for emergencies. But it may be a relatively small stock, but the chances that they may not use it are rather higher. A very busy hospital, such as the main Cardiff Hospital, would have a very high turnover of blood, and there'd be less chance that blood would reach its expiry date while in their bank. But in a smaller, less busy one, there could be a marked fluctuation in demand, and that it would be harder for them to avoid blood going out of date on their shelves. But it was an objective they all understood and shared. And some of the hospitals that found it harder to comply were ones that were a long way away from Cardiff, so they obviously couldn't guarantee to get any emergency supplies very quickly, but they have to have an inventory available to meet whatever might turn up. And one of those is a burns unit, and of course they never know what serious burdens might turn up on their doorstep, so they have to have a good inventory of blood, but there's a chance it may not be used.
And if we go to the bottom of the table, we can see that for this year that you're reporting on, 1979, 16.45% of that which had been supplied to the hospitals was returned, not used and outdated. And what would be done with that then? Would it always and invariably be destroyed by or disposed of by the centre?
Yes, that's right, yes. Of course, this figure doesn't take account of the fact that much of this would just be the red cells. Those donations would have also been used to provide perhaps cryoprecipitate or platelets or plasma. So in essence, the donations weren't wasted. It's just the red cell component could not be used within in its allotted time.
And then if we just go to a similar report from 1985 at CVHB 601_056. CVHB 601_056. You've not got that. CVHB 601_056. No? Oh, okay. Well, maybe we'll come back to that at a later stage, Dr. Napier. In terms of the factor concentrates that were used for the treatment of haemophilia A, haemophilia B, the factor 8, factor 9, you describe in your witness statement those being held at the Regional Transfusion Centre, essentially with the centre performing a warehousing function. Is that right?
That is true.
So how would it work in terms of the ordering of those products and knowing what to hold in stock? Did you simply order whatever was requested of you by Professor Bloom or Dr. Al-Ishmael?
Yes, we would. I think we were fairly passive as far as this was concerned. We took guidance from them as to the quantities and types of material that they wished for. But the Transfusion Centre had the distribution facility, so we could send the materials to whichever hospital needed them at the time they needed them.
And we'll come on to issues of self-sufficiency and plasma supply at a later stage. But in terms of the products that were received from BPL, you would hold those, the factor 8, factor 9 concentrate, as well as the commercial concentrate. You'd hold those in the centre and then distribute them to the haemophilia centres or other hospitals?
Yes, we did.
And as far as you can recall, did you have any discussions with Professor Bloom or Dr. Al-Ishmael or indeed any other clinician involved in Wales with the care of patients with bleeding disorders about whether they should be using one product rather than the other?
I don't recall that we did. Obviously, there was a general understanding that we would do our best to provide as much of the NHS material as we could, but I don't think we didn't have any expertise in deciding the choice of material for any individual patients. And so we took our cue entirely from those consultants that you mentioned.
And as far as you can recall, did you have any direct dealings, or the centre, your centre, have any direct dealings with the pharmaceutical companies who were supplying products? Or were those dealings, as it were, taking place between Professor Bloom and the pharmaceutical company, and then the products would simply be delivered to you?
I'm afraid I just don't recall the details of that. I think your statement that Professor Bloom that we've had discussions with the companies is probably correct. I think we may have had some discussions with companies about pricing and quantities, but I really can't recall that at all.
Can I then just ask you on a slightly discrete topic about the inspection or regulation of the Regional Transfusion Centre? You've set out a recollection in your statement of the centre being inspected by the Medicines Control Agency. Can I ask you to look with me at a document, NHBT 00164770. These are the minutes of a regional transfusion directors meeting on the 5th of October 1977. And if we just go to below the list of attendees, we can see it says the chairman welcomed Dr. Napier and informed members that although Dr. Bevan would not be retiring until the end of the year, she'd requested that her future successor, Dr. Napier, should attend on her behalf. So this was your first regional transfusion directors meeting, I think.
It seems to be, yes.
If we just go to page 6, bottom of the page. There's a heading Medicines Act 1968, and the minutes record the chairman welcomed Dr. Fletcher of Medicines Division to the meeting. Dr. Fletcher informed the members that the phase of informal visits by inspectors had been completed and that most RTCs had now been visited. Elstree and Liberton had also had visits from inspectors. Dr. Fletcher told the members that a meeting within Medicines Division had taken place on the 15th of July 77 to discuss the reports of these informal visits. And then top of the next page, there was to be a further meeting on the 6th of October when representatives of NBTS and DHSS would be present, when it was hoped to examine in detail the views and recommendations of the Medicines Inspectorate with the aim of producing a definitive document which would provide the guidelines of good manufacturing practice and standards in the NBTS. Dr. Fletcher acknowledged the importance of maintaining flexibility within the NBTS to provide room for initiative on the part of RTCs. He anticipated that the implementation of most recommendations would require a transitional period because of the practical considerations likely to be involved. Now, that tends to suggest that, as at 1977 at least, the system of inspection was one of informal visits, informal inspections. Can you recall roughly how often they took place?
I'm afraid I don't have any recollection of that phase. It seems the Cardiff Centre would have been visited. I'm afraid I've got no recollection of that visit or the outcome. It preceded my arrival. When the formal process of the Medicines Control Agency inspecting centres did begin, I think the inspection was every other year or something of that nature. I can't remember exactly, but it wasn't every year, but it was there was a programme, something like every other year, but I can't now remember the details.
And if we go forward a number of years to the formal inspections, NHBT 306284 this is headed Department of Health Medicines Inspectorate Inspector's Summary. We can see it's an inspection of the Welsh Regional Blood Transfusion Centre in Cardiff, taking place in October 1990. And if we just go a little further down, we can see date of previous inspections, August 1988, purpose of visit, routine re-inspection. So that would tend to suggest that once the formal process had started, an inspection taking place on a routine basis every couple of years, which would accord with your recollection.
I think so, yes.
But prior to that formal process, are you able to recall how often, if at all, there were informal inspections?
I'm sorry, I have no recollection of this whatsoever.
I'm just going to see if we can go back to the document. Have you got it? Thank you. So CVHB 601_056. Thank you. So this is the 1985 report of the Chief Administrative Medical Officer. If we go to page 7, we can see the section on the blood transfusion service beginning. Can we go to the next page, please, because it's got statistics from 1980 to 85. So we can see here, we've got a table there setting out data from 1980, 83, 84 and 85. In terms of donations collected, it looks like there's an increase from 1980 through to 1985, albeit 1985 some 5,000 or so fewer donations than 1984. And then we've got various figures for the different forms of blood components and blood products. I just want to draw attention to the cryoprecipitate figures. So we can see 13,475 in 1980, and then that reducing 1983 just over 8,000, 1984 just over 9,000, 1985 just under 7,500. I'm going to ask you a little more about cryoprecipitate at a later stage, but just going back to, I'd asked you about your dealings with Professor Bloom. Do you recall ever having any discussions with Professor Bloom about cryoprecipitate and whether you should be producing more or less cryoprecipitate over this period of time?
There may have been, but I don't recall them now. For the most part, cryoprecipitate was produced on demand. A hospital would phone up and we would provide cryoprecipitate. They would have their own inventory of stock to keep. And so we would be responsive to what the hospitals would be asking for. But I may have had informal discussions with Professor Bloom about overall long-term policy, but I really don't recall them now. But for the most part, the centre produced the cryoprecipitate that hospitals asked for, although there may have been at times when they asked for cryoprecipitate, we may not always have been able to supply what they wanted at the time they wanted to. But in general terms, we attempted to meet the orders that came in from hospitals.
And then if we look at the very bottom entry on this page, in relation to plasmapheresis, which you helpfully explained to us earlier, plasmapheresis donations at 719 in 1980, and then increasing over the following years, so 1,700 odd in 1983, 1,973 in 1984, and then 2,807 in 1985. So it would appear that in the first half of the 80s, you were collecting using plasmapheresis, but to a relatively modest extent as set out here.
Yes, yes.
And then just on the next table, next page, I don't have any questions to ask you about it, but we can see there the figures there for the units issued to hospitals and then the units returned per hospital in the course of 1985. We can take that down. Thank you, Seamus. Dr. Napier, I want to ask you next a little about your understanding of the risks and nature of hepatitis. Perhaps we can take this by reference to your witness statement, WITN 6915001, page 53. So you say in paragraph 194 of your statement, HBV, hepatitis B, had from the 1970s been a well-understood cause of blood-borne hepatitis, and procedures have been established for risky donor exclusion and progressively more sensitive blood screening tests followed the evolution of knowledge about what was initially known as non-A non-B hepatitis and then later identified as a viral transmissible illness to be known as HCV hepatitis. It was long recognised that other blood-borne viruses might transmit hepatitis. Then in the next paragraph, you say that before reliable HCV, so hepatitis C assays were developed, attempts to identify and exclude donors who might provide a risk proved exceptionally difficult, and decisions applicable to donors in one part of the world could not be applied elsewhere. Knowledge about non-A, non-B hepatitis C evolved over time, but significantly increased when the morbidity following use of pooled donation blood products emerged. And then paragraph 196, within the general transfused patient population, the very long incubation period and relatively low infection rate hampered recognition of the seriousness of post-HCV transfusion hepatitis. So against the background of what you've set out there, Dr. Napier, I just have a handful of questions I wanted to ask you. Would it be right to understand that by the time you took up your post in 1977, you would have been well aware of the risks of transmission of hepatitis B through blood?
Yes, that's certainly the case.
And you refer in paragraph 194 of your statement to progressively more sensitive blood screening tests. Is it right to understand that the tests, when first introduced in the early 1970s, were not particularly sensitive, and then as the decade went on, better, more sensitive tests came to be in operation?
Yes, I think the early tests were a manual test, and the result had to be read by the naked eye, so to say, and a judgment made as to whether the changes that the operator was looking at were sufficient to account for a positive test. The later tests, the ELISA tests, a colour reaction appears in the analytical unit that you're looking at, and this could be read by machines, and the machine would be able to precisely quantify the amount of colour change that would be taking place, and there would be a threshold which was regarded as the smallest amount of the analyte that is detectable, and so it would be objective and standardized, and it would be possible to, within that testing scenario, to incorporate samples of the known degree of positivity to be sure that the test process was picking up weak positive samples, and altogether it became a much more reliable and sensitive and standardizable system.
And if we could look, please, at PRSE 40799. This is part of a 1976 publication from the International Society of Blood Transfusion, and this chapter is Hazards of Blood Transfusion. And if we go to page 12, there's a heading, Viral Hepatitis, and that if we look at the last paragraph on that page, it says, tests for HBsAg, previously called the hepatitis-associated or Australia antigen, are now available. Although these will detect no more than about 50% of hepatitis B virus carriers, no blood or blood products should be transfused unless the donor is known to have been negative for HBsAg. It's recommended that each blood donation should be tested by such a method as counter-immunoelectrophoresis, or preferably RIA or RPHA. Does that statement that the tests would detect no more than about 50% of hepatitis B virus carriers, does that accord with what was your understanding roughly at this point in time?
I can't recall the date of this publication.
This is 1976.
Yes. Well, I think things have improved markedly over that period of a few years. And I think if you were to take the later generations of tests that you mentioned, such as the I think you mentioned a radioimmunoassay, I think that would be picking up such a low level of the so-called Australia antigen that I think it, although I don't have the figures to hand, I think it would be expected that it would pick up the majority of the hepatitis B carriers. No test will pick up 100% because some donors might be recently infected and the level of the hepatitis B virus may be too low in their blood to be detectable. But that later level of radioimmunoassay tests would be picking up a very low level of virus contamination in the blood, and I think it was expected it would pick up the majority, but I don't have the percentage of the hepatitis B carriers. But I think they had a dramatic effect on the reduction of hepatitis B transmission. But we're going back a lot in time, and I don't have details as to the success rate of those tests.
Understood, Dr. Napier. Just may assist in terms of dating when new tests became more prevalent. If we look at PRSE 40862, This is the third report of the advisory group on testing for the presence of hepatitis B surface antigen and its antibody. If we go to page 6, we can look at the bottom of the page, just so that we can see what the group was looking at. Paragraph 5 at the bottom of the page says, in November 1979, the group, so this advisory group, was reconstituted and reconvened to consider whether any alterations in the methods used for testing donations were desirable as a consequence of developments in knowledge and technique which had occurred in the intervening 5 years. That's since its previous report. The group was asked by the DHSS on this occasion to restrict its recommendations to matters directly connected with testing. And then if we go to the top of the next page, under the heading Screening Blood Donations for Hepatitis B Surface Antigen, paragraph 6, the general principles of testing were considered in chapter 2 of the second report and do not need to be repeated. At that time, the group recommended RPHA as the method of choice for screening blood donations. Since then, more sensitive tests have become widely used, and we have considered whether any of these should replace RPHA. Paragraph 7, as screening tests have become more sensitive progressively, fewer additional HBsAg positive donations have been found. The change in the testing method from counter-immunoelectrophoresis to RPHA, introduced 5 years ago, resulted in a 30 to 40% increase in the number of HBsAg positive donations found, whereas a further change from RPHA to RIA, radioimmunoassay, the most sensitive test currently available, has resulted in only a 5% to 10% increment in the UK. Paragraph 6, of the more sensitive screening tests available for the detection of HBsAg, we considered the following, and then the 3 different types of tests set out, RIA, ELISA, RPHA. And then if we go to the next page, I'm not going to go through the detail of the observations with you. Paragraph 14 is the recommendation. We recommend that all donations destined to contribute to protein fractionation at NHS fractionation centres be tested by techniques with a sensitivity of at least 2 BSU per milligram of HBsAg. With the increasing need for plasma, this would imply all donations collected for transfusion purposes at RTCs. And then paragraph 15, it's only possible to lay down approximate guidelines for the sensitivity of testing. RAA or ELISA tests should be able to detect 2 HSU per milligram of HBsAg or less. And then it said that our PHA tests are likely to be of lower sensitivity. So the recommendation in this report was the use effectively of the more sensitive RIA or ELISA tests. But it looks from the South Glamorgan report that we looked at a few minutes ago as though you'd already introduced ELISA testing into the Cardiff Centre in the course of 1979.
It would seem so, but I have no personal recollection of the dates of the introduction.
Okay.
Could we just go up to the top of that, the page we're looking at the moment? Yes, just the incidence of positivity in donors. It doesn't say how many escape the net. Yes,
I'm
thank
sorry,
you.
I don't think I understood that question. It does seem, paragraph 13 does seem a little bit confusing, but of course the donor panel changes. When you first introduce a screening test, you'll hopefully identify and remove from the panel most of the people who'll be carrying that infectivity. So for future years, you won't be expecting to detect nearly as many as when you first started. Which it explains the anomaly whereby the more sensitive tests seem to be picking up fewer infective donors. I'm sorry, I'm not sure if I've answered your question.
No, I was just struggling to understand what it meant and if it said anything about the proportion of the donor population who, though they were subject to the test, still managed to transfer infection or an effective agent to the blood they were donating. In other words, how many donations actually escaped the test at this stage across the nation?
Yes, yes. I don't have the information to hand. I think the introduction of hepatitis B surface antigen testing, particularly when it got to the more sensitive tests, had a profound change in improving the safety of donated blood. And in the Cardiff Centre, transfusing somewhat close to, a few less than 100,000 units a year, my recollection is that we might be notified of one or so recipient possibly getting hepatitis B infection per year. I'm not looking at my at more data. That's my recollection. So it did seem as though hepatitis B as a risk had been remarkably reduced with the introduction of these tests.
Yes, thank you very much.
We can take that down, thank you. Can I then come to the question of non-A, non-B hepatitis? Would it be right to understand that by the time you're taking up your post 1977, you'd have been aware of that post-transfusion hepatitis was still occurring, notwithstanding the increasingly sensitive hepatitis B testing regime, and that there was a recognition that there was something else causing post-transfusion hepatitis, which was by this stage being referred to as non-A, non-B hepatitis?
Yes, I don't think that's a reflection of personal experience. The problem with non-A, non-B hepatitis is that any clinical changes take some time to appear, and probably well after the patient has been discharged from hospital care. And so my recollection was that we were never notified at this time of any transfused patient who might have got a hepatitis, non-A, non-B hepatitis infection. I think at that stage, the diagnosis was a transient, or a period of liver enzyme elevation. That is reflecting some degree of damage to the liver tissues. There'd been no more specific test for this condition, but it wasn't a situation which we were ever notified. That's not to say it wasn't happening. I think that it seems to be, again, in reflection, very difficult to establish the significance of non-A, non-B hepatitis. Perhaps it wasn't helped that it didn't have a name. It was a rather vague term, non-A, non-B hepatitis, which could be due to a multitude of infections or other problems. But I think it took a long time to firm up the association between transfusion and this infection and liver disease. I think some liver specialists were aware of non-A, non-B hepatitis or hepatitis C and severe liver damage, but I don't think the early studies clearly showed a link in those patients with a previous history of transfusion. Many of the patients with that chronic severe liver disease or liver cancer probably had got their hepatitis C infection from other means. So it took a little while to be sure about the link between straightforward blood transfusion and this sort of chronic hepatitis. The pattern showed up much more obviously in the recipients of pooled products, when of course any given recipient will be getting donations from hundreds, if not thousands, of donors, and consequently a high possibility that one of those might be infected. But it took a while to crystallize the link between a conventional blood donation and non-A, non-B hepatitis and severe liver disease. It was recognized there was a period of liver enzyme elevation, but I think certainly, I think my understanding at the time was that we weren't really sure that in the form of conventional blood donation of red cells or or platelets or cryoprecipitate, we weren't aware that this was leading to significant morbidity and mortality in terms of chronic liver disease. And I think it's to be regretted that it took a while to be sure this was a serious problem. But my feeling is that in this late 70s, early 80s period, and again, the dates are a bit vague in my mind, I don't think we were as afraid of non-A, non-B hepatitis as perhaps we should have been at the time.
And you said in your statement, if we just go back to it, WITN 6915001, page 53. Paragraph 196, and you're dealing here with the general transfused patient population as distinct from the pooled donation blood products population that you referred to in the previous paragraph. The very long incubation period and relatively low infection rate hampered recognition of the seriousness of post-HCV transfusion hepatitis. In terms of the long incubation period, can you recall whether there were discussions amongst regional transfusion directors, or either between themselves or with their consultant colleagues, in the late 70s or the first half of the 80s, about the fact that you might not be seeing the long-term consequences precisely because there was a long incubation period, and that you should perhaps be erring on the side of caution in recognising the possibility of that incubation period?
I think with hindsight, that may be the case. I don't actually recall much discussion about non-A, non-B hepatitis. That's not to say that there wasn't any, it's just that I don't at the moment recall it. And I think it comes down partly to, it took a while, and again I can't remember dates, it took a while to recognise the link between this chronic or end-stage liver disease and the history of transfusion. Many of the patients that the liver specialists were dealing with that severe liver disease hadn't been transfused, and so the transfusion history wasn't initially recognised as being an important risk factor for end-stage liver disease. Again, I think from the transfusion population, we were just not aware of the, at least, well, perhaps I speak for myself, not aware of the degree, amount of morbidity and potential mortality of this non-A, non-B hepatitis.
And so would it be right to understand that, insofar as you can recall, in the late 70s, first half of the 80s, non-A, non-B hepatitis was relatively low on the agenda in terms of issues that the regional transfusion directors were considering?
Well, this is my personal recollection. Others may differ, but I think it was perhaps dominated by the need to attend to other aspects of blood safety. And I don't think non-A, non-B hepatitis loomed perhaps as large as it should have been in my consciousness, certainly.
And looking back now, in retrospect, do you think that you and your colleagues were too slow to recognise the potential seriousness of non-A, non-B hepatitis as relevant to transfusion practice?
Well, I think we would all have wished things had been done differently. I mean, the infectivity of the donor population probably changed. I think transfusion, the early years of transfusion, I imagine the likelihood of non-A, non-B hepatitis was quite low, but with the increasing incidence of intravenous drug use in the population, probably greatly increased the prevalence of the hepatitis C virus. And so the donor population, which was relatively risk-free in the early years, changed over time. And I don't know how many of us were familiar with the actual the actual changes of, how many intravenous drug users were and the general prevalence of hepatitis C population, hepatitis C infection in the population. I don't know if any of us were really aware of figures for that, even if there were figures. Well, there wouldn't have been figures before a serological test for non-A, non-B. So I think the risk changed over time from being relatively very small to being rather larger. But the risk in the UK population was much less than many other in many other countries where we've now, in retrospect, we now know that the prevalence of hepatitis C is much higher than it is in the UK.
That leads on to the next issue that I want to explore with you, Dr. Napier, so we can take the statement down, which is the issues about donor selection and donor screening. Just before we come on to that and to some of the policies and practices in that regard, in terms of the donor sessions that would have been organised through the Cardiff Centre, we've looked at where those took place already in the different geographical areas and in workplaces and factories. Are you able to assist us in understanding how it was decided within the centre how much you might need to collect for a given month or a given year? Were there particular targets that would be set and then revised on a regular basis?
Yes, this would have been reviewed. Obviously, we've got a historical trend for increasing blood needs each year. So during the planning cycle, we would have built in an assumption that there'd be a certain percentage growth in blood requirements, and that would be fed back to the donor recruitment teams who plan the sessions and plan the numbers of attendees at the sessions and might decide whether to try to open up new collection opportunities, such as approach factories that we hadn't visited beforehand to see if they could host a blood donation session, or other opportunities for blood collection, such as this vehicle we call a blood mobile, which is a large vehicle which is self-contained as a blood donation session. It can park in a large car park, and donors can be bled actually within the vehicle. All these opportunities for blood donation would be considered when we were looking at the next year's targets for blood collection.
And was it common for there to be shortages and a need to have an immediate increase in donations?
Well, not very common. Shortages, the very fact they're shortages means that I think an unexpected surge of demands catches the hospital blood banks and blood centres, catches them wrong-footed. The problem with blood supply is that because the shelf life of blood is relatively short, you can't hold large inventories, and blood comes in and goes out fairly quickly. But if there's a sudden surge in demands, it may deplete the stocks in blood banks or deplete the stocks in the transfusion centre just temporarily, and there's no quick fix for that. You can, within a day or so, you can try to do your best to ramp up collection from donors, but it's not something that can be done within the space of a few hours. But a conjunction of a few medical emergencies can suddenly just mean that blood banks are depleted and can't meet all their needs. But for the most part, in the latter years, these were quite rare events. I think many of us in transfusion can remember earlier times when the shortage of blood prevailed, and I can certainly remember long before I came to Cardiff, working in hospitals where it was sometimes necessary to ring around blood banks just to see if you could beg and borrow some units of blood for a particular medical need the next day. But I mean, by and large, regional transfusion centres, for the most part, contained most of their needs. But there is unpredictable fluctuation in supply and demand. And so every so often, even the most successfully run centre will run short and need help.
And what strategies were deployed by the centre to attract more donors? Was there advertising or publicity, or what ways of trying to increase the number of donors?
Yes, there'd be radio appeals and press appeals, and also there'd be, if sessions were being organised in factories, there might be telephone calls to those factories for an exhortation for every possible donor to attend. And so a variety of measures were operated to try to boost demand. And by and large, I think they were very successful.
Now, could we look at CBLA 301905, please, Shomik? If we go to the second page, these are the minutes of a meeting of the Regional Transfusion Directors, 10th of October 1984, and we can see from the list of those present that you were in attendance. If we go to page 4, there's a heading, Medical Staffing of Donor Sessions. And I just wanted to read this and then ask you some questions about how things worked in the Welsh service. So it says, Dr. Harrison reported some nurses are in training. The BMA is preparing a paper jointly with the region to put to the Joint Consultative Committee. Again, the comment was made that we are independent regions, although in many matters there's agreement and a national policy. And then there's a discussion about the views of unions. It says the Defence Union would not recommend a nurse could be in, while the Defence Union would not recommend it, a nurse could be in sole charge at a session if it is considered that this is an appropriate job for a nurse and that he or she is properly trained. If this is so, then the nurse takes responsibility for the performance of the job and not the consultant. If there's litigation, the Regional Health Authority bears the responsibility. The training and assessment of the nurse are the responsibility of the Transfusion Director, and obviously high standards must be met. And then it says, to meet the requirements of the BP and other statutory bodies, a doctor must judge the fitness or otherwise of the donor. It may be that we're not currently using the medical officer fully on sessions. It is accepted that a nurse could, with comprehensive training and experience, perform venipunctures and first aid on a session perfectly well. Almost all members felt that it would still be essential to have a doctor present for donor screening and legal cover. And then the next paragraph says, much of the screening at present is done by the clerical officers and donor attendants according to the set guidelines before the donor sees the doctor, whose time is almost entirely occupied in performing venipunctures. There was some concern that without a doctor, donor queries would be deferred more often to await a decision at the RTC. With consequent loss of donors, this might undermine the cost-saving aspect of the scheme. The majority of RTDs were sympathetic to the extended role of the trained nurse in carrying out venipunctures within the transfusion service, but insisted that a physician must be present at a donor session. And then if we skip over the next paragraph, the final one says, the chairman asked how many RTDs would feel happy at SRNs performing venipunctures and running donor sessions without a medical officer being present. The majority agreed that a medical officer must be present. The concept of nurses in sole charge was supported by only 2 RTDs and 1 other gave qualified support. So we can see that, Dr. Napier, a discussion of the role of the medical officer, the doctor, the nurse, and then the clerical officers and donor attendants. Can you recall what the staffing was of the donor sessions that were operated under the auspices of the Cardiff Centre?
At the time this discussion was being held, the Cardiff Centre would have had medical staff undertaking the venipuncture and making the more complex decisions with regard to suitability of donors. There is the background donor care and selection documentation which would have been present at all blood collection sessions, which in detail describes the criteria that had to be met by donors to make them eligible to be to donate blood. Now, many of these things would not be too difficult to decide about if a donor admits to a certain condition, even at the clerical booking in stage. So that's not a difficult decision to make. Where there's an element of uncertainty or discretion, then at that point the medical officer would be asked to intervene and would take the donor aside and question them for clarification and make the final decision as to whether or not the donor would be eligible to donate. So when this discussion is taking place, doctors are doing the venipuncture and making the final decisions with regard to eligibility of donors.
And then did that change subsequently in relation to the sessions operated by your centre? For example, there's a discussion here of nurses taking on that role. Did that happen as far as you can recall?
Yes, it did. I don't recall the dates in which that happened, but I think there's a change generally, as I understand it, throughout the regional transfusion services that state-registered nurses took on these roles. The position at Cardiff was that there was always a telephone line access to a medical staff. So if the situation that the donor presented at donation was more complex, then it was always possible to ring up a doctor and to make the final decision about eligibility to donate.
So what I want to do next with Dr. Napier is look in some detail at the memorandum on the selection, medical examination and care of blood donors, the very guidelines that Dr. Napier has referred to. It's going to take longer than 3 minutes, so I wonder whether we take lunch now and then we can pick up that document after lunch.
Well, let's do that then. We'll take a break now for lunch and come back at 2 o'clock. So 2 o'clock, if you please, Dr. Napier.
Thank you.